that this many people came to watch something as dry as synoptic reporting. You guys are awesome. So I'm Scott Campbell. Most of you guys know that already because I think I know most of everybody here. But for those of you who don't, I'm Scott from the University of Nebraska Medical Center. You know, most of you guys are from the States, so I guess I don't have to tell you where that is. Yeah, except for you, Matt. It's the middle of the middle. I know, but do you know where it is?
No.
Okay, there. Do I need to tell you, Matt? No. Okay. So this today is really more of a training workshop, maybe an informative workshop, but it's really the culmination of, well, frankly, 10 years of work, but 3 really hard last year's worth of work and a completed product that's really ready for the user community. So this is the first, I hope, of many increasingly better, please. Hopefully we start high, but you know, if we don't, we always can get better. Training sessions and efforts to help people understand the content that was created, how to implement this, how to deploy this in your clinical information systems. And that's cancer synoptic reporting, structured cancer synoptic reporting using SNOMED CT. All right, so 3 real objectives for you all for this today. Understand the content that we developed as part of the cancer synoptic reporting work group. So this has been a functional working group, a formal working group in SNOMED International for the last 3 years. And it was if you would authorize by the member forum, and off we went. But it developed. It basically takes work that was done. From when we crashed a party, Jim Campbell, myself, a few other pathologists crashed a party in a SNOMED business meeting party in Chelsea. It was awesome. Ian didn't know what to do. Jane didn't know what to do with it. Who the hell are these guys? That was the best bacon I've ever had at that. We should always go back to that hotel. I don't know why we don't. Develop an understanding of implementation and approaches to implement cancer synoptic reporting, and really just discuss some methods of querying synoptic data sets, because you know there's a paradigm that goes with cancer synoptic reporting that we have to understand, and it's more it's the mechanism by which the clinicians are recording their data, but that has implications on how we instantiate that data in our data sets and then how we query that data. All right. So just an overview of what we're going to do. We'll review the pathology process. So for those of you who are not used to or not familiar with surgical pathology, just going to be kind of a flyby on that. Then we want to define really what this problem was that we were trying to solve with SNOMED. An overview of the content and the content development process we used, and some specifics about the content itself, implementation methods, and then finally data analytic methods. Okay. So my friends from the CAP and others know this process well, but for those of you who intersect often with anatomic pathologists and well, you never see them anyway. They're always stuck in their room, so they don't talk to their patients are all on glass, so they don't really interact with people. So we have to kind of explain their process. But so pathology in general, internationally, when we say pathology, oftentimes we conflate anatomic pathology with clinical chemistry, things that are in the laboratory. So really, here we're going to talk about histopathology and the parts of laboratory medicine that are specific to tissue, and the evaluation of tissue for cancer. And histopathology, that's how folks outside the US like to call it. It's the microscopic examination of excised tissue. And so just to frame what we're doing, and really histopathology still is the gold standard in the diagnosis of cancer. Radiology can say, yeah, that looks bad. There's lots of things that in the clinical domain we can say is bad, but ultimately we pull out pieces of tissue and say, yeah, it really is bad. This really is malignant. It's nothing shy of that. So, all right, well, that's the histology practice. And so Eric here is a pathology assistant. So he's the guy who You could ask him about gross room stuff when we get to gross room things. So how does this all start? Well, patient has something that has been identified as a lesion or a lump or a mass or something like that. And there's a surgical procedure that takes place, and depending on the level of where we're at in the diagnostic process or in the treatment process, it could be as simple as a biopsy, or it could be as radical as a resection and a very large resection. So basically, a surgery is ordered, surgery starts taking place while the patient is still on the table. Yeah. Wow. Yeah. Yeah. All right. So while the patient is still on the table, hopefully still anesthetized, basically, the surgeon starts to excise the tumor, okay, and that let's just presume this is a larger tumor. So the surgeon is trying to remove this thing from the patient, and this thing could be from this big. I mean, it could be teeny, it could be this big, and it could contain lots of things. So it could be, let's say it's the colon. It could be the colon. It could be tissue around the colon. It could be parts of organs, juxtaposed to the colon. It certainly will be lymph nodes and other things like that. So the surgeon takes these pieces of tissue out, and based on how the surgeon extracts them, right, they're called parts, and those parts get sent to the gross room. Yes, and you get this thing, and it's gross because big and disgusting, but mostly because it's big. And these parts, while the patient's still open, go down to the gross room, or the gross room is proximal to the surgical suite. And people like Eric, or a resident or an attending, will look at that piece of tissue, right? And they'll make a quick assessment. They'll describe it, and it's this big, this way, what it weighs. They'll take a snippet of that tissue on a place that looks bad. And this sounds really bad, but individually quick frozen pieces of tissue, freeze it, cut it real quickly, put it on a glass slide, stain it with a quick stain, look at it under the microscope really quickly and say, cancer, not cancer, right? That's typically the first thing they do. The second thing they do is they look at the margins. Say, looks like you got it. Right, looks like this is that you've from a down and dirty perspective, you excise the tumor at this area. Okay, and we'll do this for each part. Okay, once the gross folks have said, hey, doc, it's okay, I think you got the whole tumor as best as you can, the doctor will complete their surgery, and the pathology process continues. So basically what happens is you have this part, and it could be depending on how big it is. People like Eric will excise components of this gross piece, this large piece of tissue, and they'll put it in jars of formalin. Formalin stops the metabolic process. So basically freeze. Right, and all cells, everything freeze where they're supposed to be. And the float's there for about what is it? I forget how many hours per inch of tissue, but 4 to 8 hours, something like that, to stop the metabolic processes. Once that's done, it's sent to our histology lab, and basically they take these pieces of tissue and they basically run it through a series of baths and embed it with paraffin. Okay, so these are pieces of tissue stuck in paraffin wax, right, and infused with paraffin. Those are then microtomed to about, is it 3 microns? Yeah, 3 to 4 microns thick. Okay, so really thin pieces of wax with tissue in it. They're put on a glass slide with a cover slip, and then those are put through, depending on how automated your laboratory is, it goes through a series of stains. And one of the first stains that we always do is something called hematoxylin eosin, or H&E. And what that does is it Blue is acid, red is basic in terms of the chemistry of the tissue. So basically your nucleus is ribonucleic acid. It's an acid, it will stain dark blue. So, pardon? There you go. And the blue, the badder, the bluer, or something like that, depending. All right. So that slide, those slides, the series of slides, are sent back to the pathologist for examination. Usually it takes 24 hours from surgery to slide prep staining to get to the pathologist's desk to start their microscopic examination. Okay, so they evaluate this and they look at each slide and they look for architectural patterns that are normal, architectural patterns that are not, and when they're not normal, they describe them. There's a second phase, depending on the type of cancer or making differential diagnoses, they'll also use immunohistochemistry to determine basically the proteins that are there, if you would. And from a differential diagnostic perspective, we'll use proteins that tell us, is this to determine is there invasion present? If it's hard to determine, we can use certain types of stains that tell us and tell us or confirm the organ of origin, because our cells express proteins that are different when they come from different organs. And then oftentimes we'll use these for prognostic stains. So estrogen receptors, progesterone receptors, HER2/neu, Ki-67, various others, depending on the type of tissue that would be prognostic, that will be telling us something about. I know this is not exactly right, but it's almost like genomics by proxy. And then depending on the tissue we're looking at, we may even go to some forms of genomic analysis. It could be fluorescent in situ hybridization, all the way to cytogenetics or even sequencing, right? And then ultimately, the pathologist takes all of this information, assembles it, and renders their final report, okay? There you go. So that's the process of pathology. Something, just depending on where you're coming at it, here's, if you would, an ER diagram of the process. So if you would, a patient has a case, and the case can have one or many parts associated with it. Each part will have a gross description, right? How big it is, what it'll look like, what's it weigh. Each part may, well, you guys don't need to know that. Each part will have multiple slides. So it'll have lots of microscopic data. Parts may have special studies associated with it, or many studies associated with it. Collectively, they all come to a single final report. So in terms of, the reason I bring this up is, it's a kind of an IT way to look at pathology, which is important if we're implementing and we're not pathologists, to understand the information model, if you would, and we'll go with that. So, oops. Okay, so let me just, bear with me, this got to go away. Because I'm in IT, I get all the messages that, oh my gosh, the system's down. Somebody's gonna. There we go. All right. So use cases here. So what I'm going to refer to today, by the way, is we have an implementation guide in the offing. We will upload a PDF of the current version, but we don't think it's full enough yet to publish. We want to have some more things there. But these are all contained within the implementation guide, and it's on Confluence. And here you go. And we will get you a download of this. And so there's a whole implementation guide that will be going along with this, and it'll summarize or actually expand on a lot of things I talk about today, and hopefully offer more. So most of you know how these things are used, but basically these are some examples that that those of us in the project group and the implementation team started throwing together. The patient with early stage breast cancer undergoes a lumpectomy. Synoptic report diagnoses documents all the details about the tumor and its characteristics and prognostic. Some prognostics and treatment plans are basically started after that, if you would, and these are all just variations of the same. Problem is, the reports that we deal with typically look like what you're seeing. This is a snippet right out of University of Nebraska system. Okay, a right lumpectomy, residual invasive mammary metaplastic carcinoma, and it's almost a centimeter post therapy. Margins are negative. Prior biopsy clips are identified. Where the things were taken. The stage is a YPT1 MI Y SN PN0 I minus. Yeah, that's shorthand for it's not as bad as it could have been, but it's still not great. And I think that's basically what a layperson would say. Notice there's nothing on the skin resection that was included, and there's stuff with the lymph node, and I just cut it out. So basically, there's a lot of information that's in there. It's lost to the PDF. It is not computable. It's great to be read once, and unfortunately, it's gone, right? It's gone for continuity of care for the patient. It's gone for research. It's gone for public health. So it's just, it's lost to the PDF. I like to tease my pathologists at work that they lose knowledge at the rate they sign out cases. So, this is one of the problems we're trying to fix. So, all right, the pathology report contains a ton of valuable information that we use for patient care. The first and foremost thing that we use this information for is for patient care. If it were a biopsy, is it cancer or not? Yes. And what are the critical things we need to know? On a biopsy, you just take a small piece of tissue, and let's say it's breast cancer. It's cancer, right? Usually we can get the histology. We're not going to be able to get the grade. We might get some grade. We're going to be able to get some immunohistochemistry information about it, ER, PR, HER2, and those are huge for prognostics and immediate treatment planning. Unfortunately, the final report is usually done after treatments when the ultimate tumor is resected. It's already far along in the care process because the patient's more than likely now had a bunch of neoadjuvant therapy, whether it's medical or radiation or a combination. The tumor shrunk, we hope. And by the time we do the resection, this is not a novel tumor anymore. It's been treated. So there's some issues there, but that's okay. For public health, so for people like Sandy who run registries, this information is critical because it goes into our registries and helps us characterize what's the societal burden and then incident rates of certain types of cancers on certain populations. What are the treatments that have been applied to this patient? What's been the outcomes? Because we have to be ready. Unfortunately, this damn thing called cancer ain't going away anytime soon. And, we've gotten better at treating it. In certain cases, if certain types of cancers, are no longer death sentences. You can just die from taxes. But others are you'd just be glad if you had to pay taxes for one more year, right? Because the cancers are that bad. Unfortunately, right now they're often textual, and so it really begs the question: how complete is that information in the written report? And we'll talk about that in a little bit. How easy is it to find the information you're looking for? And because it's lost to the PDF, it's really, yes, it's really a one-time, it's one-time use, and then file it away as a paper document somewhere in the EHR, and it'll be lost forever. Certainly not computable. So every knowledge expression has to be extracted manually again. I thought we were migrating our medical fellowships away from chart abstractions, but then again, maybe not. And it just can't be reused easily. right? We can't leverage it to gain knowledge. We can't leverage it to find patients for clinical trials. We can't leverage it to identify patients who may become eligible for a new therapy. It's really most unfortunate. So entering synoptic reports. So John Shrigley, who's from Cancer Care Ontario, and he's still with us, part of the CAP, and leads an international organization called the ICCR, the International Collaboration on Cancer Reporting. Laid out kind of the evolution of what's going on in cancer reporting. You know, at the beginning of time, it was narrative, and I call it pathology poetry. You know, pathologists would tell all the beautiful things and formations and, oh, you know, the sun rises and sets on their description of what was going on. At the end of the day, the surgeon just wants to know, was it cancer? How bad is it? And what do I do next? Right. So over time, there's been this evolution to become more structured. You know, with required pieces of information that should be contained in the report. You know, then how do you lay it out? And then can you encode it? Can it become machine readable? And so each of these levels of reporting build on the other. And you know, when I was presenting something years ago, John Shrigley was there, and he goes, boy, what you're talking about by applying SNOMED CT to this is you're actually talking about a semantic representation that's not just computable, but it also carries meaning with regards to what is contained in the report. So that's what we're trying to do. So what does it look like? So this is a typical level 2 report. The only thing that matters for patient care is in red. Everything else are filler words. So it's a beautiful report, and I'm sure that, you know, the pathologist thought long and hard about it and made sure there's a plot, and, you know, there's a rising action and falling action and the whole thing. But at the end of the day, the surgeon just wants to know, did I get it? And what do I do next? We start to get into structured reporting. This is more like a level 4 type report, where we're starting to see, you know, care headers for certain sections or need to know observations and what that observation was. And now, again, you know, most of what's necessary to treat this patient is in red, but it's much more structured and well put together and easier to follow. Then comes this thing called structured reporting by the CAP, ICCR, PALCA, the Royal Colleges, where they start to say, you know what, we're going to start putting something out called data sets or synoptic reports. They are the minimum required data elements that the pathologist needs to report to the surgeon, to the oncologist, to communicate what this tumor is and its characteristics. In solid tumors, it's often all the information that is contained in these reports is used to render a stage. That's shorthand for bad. It's a surgeon thing. You have to speak in short terms because they play with knives. At any rate, the other thing that we've noticed is that they're all the same. The layouts are different. The language is different. Some people spell tumor funny. But, you know, the information that's contained in these reports is highly concordant, which is interesting. So, no, there was all sorts of animation there. There we go. Ultimately, when we use these forms, the report starts to look like this. Very readable. Only the information that's necessary to treat the patient or determine, you know, the prognosis of the patient is present. It can include, as you see here, ancillary testing. So in this case, this is a colon report, and mismatch repair is described. That's an important feature to assess immediately. You know, is this part of the underlying condition? Will indicate types of therapy necessary to determine if this patient has a familial condition for cancer, that'd be Lynch syndrome. So I'm not just making this up. This is in the literature. And the Dutch have been fabulous in documenting this. What happens when we use synoptic reports is there's a notable increase in completeness of the report. So data is not left out, critical information is not missing, is very readable. We all know surgeons, they don't have time to be futzing through a lot of prose. They want to look at a report and yep, that's what it is. Good, move on. I've got to scrub in for the next case. So that's important. It also renders or allows for the information to be more readily computable. And we'll get to that. And the computability, actually, Cancer Care Ontario showed just the fact that we could compute against this, even without an international standard, they could identify areas in hospitals throughout provinces where, for example, radical prostatectomies were being overperformed, at a rate that was above a typical norm. And using structured data, we're able to kind of find out which hospital in the province, down to the physician in the province, who was not following current practice. And so they were able to train this person. And so in other words, this person was, overcalling cancers ultimately, and resulting in too many radical prostatectomies. So it was a way for quality to be assessed in addition to clinical data. This is the type of information Sandy and I talk about, that this should be once it's rendered, and if it's in a computable form, it should go directly to our registries. Paul Seegers from PALGA, it does go directly to the registry. There's no translation, there's no chart abstraction, there's no, army of chart readers, and it's immediately available, and the public, our public health authorities can work with folks. Our researchers can find things immediately. We're not waiting a year and a half to get that information, right? Which is about a year and a half to 2 years for a case to show up in the U.S. registries right now. We don't want to see that. And it makes our data available for research and translational sciences. All right. Here's our data problem and what we're trying to solve. There's been no standard representation for the data elements for the cancer synoptics to realize a level 6 or 7, so fully computable report. The closest we've gotten is something called the C-keys, published by the College of American Pathologists, which is basically an inventory system of data elements. Every data element has a number, and it's unique to the worksheet it's on. And so in essence, if you have the giant decoder ring, you can figure out which data, the data is pertaining to. It's not computable. It's not going to tell you how one thing relates to another, but it certainly was a start. And Edith Nottinghal and others have been from the Netherlands have been able to show that when this is in place, they can actually realize level 6, full computable representation of this type of information. But what CDC discovered, they did a reporting pathology protocol studies that were written up, the final reports in 2005, and then again in 2009, and basically evaluated the ability to take information from the College of American Pathologists structured data sets and use SNOMED or LOINC to get it into the registries. And it was determined that none of those terminologies were sufficient to make that data unambiguous once it got into the registry. So they said, don't do that, please. And basically, an example was the SNOMED observable was histology type, full stop. And let's say the observation is adenocarcinoma. You put that in the registry, and adenocarcinoma of what? There's adenocarcinomas everywhere, so it doesn't help what we had in the past. So our objective in the Cancer Synoptic Reporting Group was to address that gap. So here is specifically the objectives: develop all the SNOMED CT concepts necessary to fully and unambiguously represent all required path synoptic data elements. Okay, so that was it. And that was the boundary, if you would, of the project. we had to make sure that all the concepts were unambiguous and fully represented each data element after it was separated from the mode of collection. So you got your synoptic report, whether it's manual or digital. Once those data elements were potentially could be separated in a registry, we wanted to make sure that they maintained their context. So histologic type of a breast cancer equals adenocarcinoma, for example. Now we maintain the context that we're looking at a adenocarcinoma of the breast, Nottingham grade of the breast carcinoma. All of these things are important. So we wanted to make sure that the meaning of the data was maintained without any reference to the form used to capture it. So underscore. We did not want anything that would just be a number, a concept ID, and a word string. It's not computable. It's nice to read. It allows you to compute with. So, all right. So we also then said that whatever content we build has to be suitable for use by the College of American Pathologists and their data sets. They cover 50% of all pathologists in the United States use the forms electronically. The rest try to bootleg it. The ICCR, RCPath, Polga, and RCPA. So it has to represent this body of pathology broadly. But the two primary producers of massive content are the CAP and the ICCR. So those are the two primary entities we focused on, to say, all right, fit for purpose, not fit for purpose. How are pathologists asking this question and recording their answers? So that's what we used. Project status, 100% of all solid tumor data sets are done, adult and pediatric. So depending on, when I say done, all the content has been developed for that. So it was well over 1,000 concepts that needed either brand new authoring or significant remodeling to be fit for purpose. We're currently working, Anna and Eric here, with the CAP and on the PERT committee, which is the electronic reporting team. So we are in the process of validating 24,000 rows of data. And once that is done, SNOMED will be embedded in their electronic release and distributed throughout North America and included in their release packages. We're doing the same thing with the ICCR, and we're just then working out what are the best mechanisms to distribute that and make that content available to as many people as possible. So, all right. Going into the synoptic structure. So let's talk about that. A structured cancer report is really a series of questions and answers. You can almost think of it as a blood panel, right? I want to complete a CBC, and if I order a CBC, I'm going to have a bunch of ordables and performables, and we get a litany of results. The synoptic report is kind of the same. Give me a pathology report. Okay, and here's a bunch of questions and observations, or things to observe or measure, and what those measurements were. Our approach is the questions, or are the features of the tumor that the pathologist is supposed to make an observation about, and we say that the question carries all the context. The answers, if you would, is exactly what the pathologist did observe. Okay. A key thing here is the cancer pathology report is a series of paired data elements. The thing to be observed and that which was the thing or the observation. They have to be carried together. And that's important in terms of system instantiation and data storage. We did not determine what was important. It was the pathologists and the societies of pathology that determined what was important. So that covered the work. There were several pathologists in this group, but the pathologists, SNOMED doesn't determine what should or should not be modeled. The pathologists and their data sets tell us what should and shouldn't be modeled. They're the experts. Okay. Here's a list of the types of content that were a pretty long list, not comprehensive, but These are all the areas effectively that we covered, ranging from silly things like tumor site, which is not silly, but it's important, but tumor dimensions, histology type, grade, locations invaded, the invasiveness of the tumor, both directly and metastatically. Since we're talking about resections, the presence of a neoplasms or neoplastic tissue at the margin, how lymph nodes were involved or not involved, that type of thing, and ultimately the TNM. So, any questions? Just take a breath for a minute here. If anybody has any questions before I continue to blather on. All right. Goodness, we're going through. Time is flying. Okay. So, a couple things. So, assumptions. You need to know when you look at the content, because it's all new. You need to know a few assumptions that we made. One, observable hierarchy is the area where most of this content, the new content, resides, because the question carries the context to unambiguously represent the answer. Okay. Explicit pathology knowledge is not carried within SNOMED. So what do I mean by that? Because a pathologist has knowledge that they're expressing. So let's a brief example. Mucinous tumors happen throughout our body. That's one type of tumor. However, what makes a tumor mucinous in the breast, for example, versus the colon, there's a cut point in the amount of mucin that is present in the tumor. And Eric, you can help me if I'm here, but if in the colon, 50% of that tumor mass has to have mucin in it to be considered a mucinous adenocarcinoma, whereas in the breast, over 80%, right? So we are not trying to represent that breakpoint of what defines a mucinous tumor in any particular organ, but we will tell you that there was a mucinous tumor in this organ. That means the pathologist would have ascertained that there was sufficient mucin to make that breakpoint, whatever that was. Okay. All right. And actually, that is the example. So what the pathologists assess and interpret is the answer. So we can make a big argument about what a positive ER positive tumor is. And we would have discussions like this, and the pathologists would say, but you can't just say it's positive, it's how many percent cells of this and what type of, what was the monoclonal antibody you used, and was it strongly there? Or so that's your guys' business. But you ask the question, is it either positive or not? That's all we care about. There's other data elements that we can add that would tell somebody who's a pathologist who would care, what were the supporting data elements to your ER positive call? But we just care that it's an ER positive call, and that's all the surgeon's going to care about. So, we had to make those decisions, and that was a big deal with the pathologist because they really wanted to know they wanted their ditzel to be represented. They're very, appropriate, but we have to make those balances in the terminology. Okay, so what did we ultimately do? Here's an example. So what we've done is every data element and every synoptic report has been encoded. So this is a blip from the histologic type of a colon neoplasm as represented in the ICCR format. So on the right-hand side, you see the data elements, the bolded text histological tumor type. Again, apologies for the misspelling of tumor there. But basically, that's the question. And if you would, the blue arrow points to the left, and there's your SNOMED concept: histologic type of primary malignant neoplasm of cecum, endocolon, endorectum. Long discussion about cecum, endocolon, endorectum. This is a colorectal tumor. Colorectal tumors behave the same, but there's really not an organ called the colorectum. So,
I never asked this before, but in the previous slide, the decision criteria, is that built on the question categories we're building? So like your category is decision criteria. Are we building that into the definition?
No.
I think we were at the
So the pathology,
that was like, oh man, that could be.
he's going to have palpation.
external standard that would exactly explain them.
Okay.
And it would be possible, I think, to reference that.
Right,
So
so with another-
according to this standard, this was a. So that's.
Oh,
Excuse me,
Sort of all.
all right. Ask
All right,
the question again.
it's Eric from the CAP. I was asking the question about the decision criteria on this slide. If it was built into if that decision criteria is built into the questions SNOMED concept. And I believe Scott, you answered, no, it's not right now.
For pathology knowledge, no. And actually, there's a good question coming up. But when it comes to technique on certain things, yes. And so we'll talk about that. Go ahead.
You just gave the answer to the, so that was really nice because it reference those particular methods or
Mhm.
standards that apply for
Mhm.
this. And that is what you just said, that is done in some areas, but not in all areas.
Yeah.
And that's probably fine.
And for an example, is, and I can't remember if we have a slide that specific to this, but histologic grade of a colorectal tumor. Okay. In the United States, we still use a 4-tiered grading system, GX through, which is, we don't know. 1, 2, and 3, like 1, it's, well differentiated, and 3, it's a mess. And elsewhere in the world, they use World Health Organization version or 5th edition of the Blue Book method, which says high or low. So we did that intentionally, and Paul and others were very engaged in that. So we call out the technique when there are no published techniques that are well adopted internationally. And the importance there is that we can then test proximity is a way I like to call it. When we compare content across multiple publishing bodies, we'll talk about ECL queries in a little bit, but I look at histologic type of colorectum neoplasm and any children of that, and you'll find that one of the children is histologic type by World Health Organization. And so when we do that, we get an entire list of possible ways that people measure, and then using a data set that we're starting to build out what the answers were based on publishing bodies, so we can see differences, whether it's between the CAF or PALCA or ICCR. So that helped, Eric. That was probably a lot longer than we wanted. Yeah. Okay. So basically, what you have here is a terminology binding to the ICCR form. Okay. And ultimately, if this was a rate of adenocarcinoma, then we have a paired value. The histologic type of the primary malignant neoplasm of the colorectum is a serrated adenocarcinoma. Full stop. So there are bindings like this for at least 24 of the ICCR data sets as we speak, and I'll get into how we're going to share that with folks. Okay. Any questions up to anyone? Okay. This is, so those of you who are SNOMED wonks or have had to play in SNOMED when it relates to this, there's content in SNOMED that dates back to beginning of SNOMED time. I think it predates Keith Campbell even. And it's in the tumor findings hierarchy. And all of it is primitive, but it'll say perineural invasion absent, perineural invasion present, things like that. We chose not to go that route. One, and there was an argument, Jim Case and Jim Campbell and I would banter back and forth, but we chose to go with the observable entity observation approach. One, it fit, right? It fit the use case. 2, it was novel, and at the time, the observables needed a tangible use case to really test it. And 3, we were going to need to do something with the machine readable concept model, one or the other, to address it. Either we were going to do it in a novel area, which was fungible, where we had some flexibility, or we would have to start changing things in the clinical findings machine readable concept model. And that's a far more mature model, and moving things there is a little bit more scary. So yeah, and then there you go. I did cover that. The other thing that was important is if we go, and there's still people who want to use the tumor findings. But if we were going to be unambiguous with tumor finding definitions, we would have to make a tumor finding concept for every question answer pair in every synoptic data set. And just looking at histologic type, you would have hundreds of concepts that you'd have to maintain. And if you've looked at some of the data sets, particularly, let's say, ovarian cancer and fallopian tube cancers, I think there are about 50 to 60 different histologies that are in the constrained list. And that's just one protocol. So we really chose not to go that route. Okay. All right. So they're wonky people. These are the properties in the observable entity hierarchy, or the attributes that we used. So how an observable entity is built, it's an assessment of a property of something. Okay, and we used we had to create a couple of property types because they didn't exist. So histologic type, histologic grade. But presence absence, we're measuring presence oftentimes. Is the tumor present in this location? Is it anatomic location? We'll talk about some of the nuances. There's this crazy concept drives most people nuts just because of the way it's labeled, but it's called in, here's in. So basically the property that you're measuring exists in something, some entity. And in this case, most of the time it exists in a malignant neoplasm. Okay. This is different than where that malignant neoplasm is. That's its inherent location. So a histology type exists in a neoplasm. That neoplasm could be in the colon, in the breast, in the small intestine. So that's your inherent location. We have this other thing called characterizes, and this is an important process. 95% of all tumors we can determine the primary site. About 5% we will never be able to determine what the primary site is. So characterizes we use to assert is this primary. Do we know the primary location? So I can have a colon, I can have a neoplasm of the colon, but I could tell you it may not be the primary because I couldn't determine that. 95% of the time we can. So histologic type of primary malignant neoplasm of the colon would have an attribute characterizes equals primary malignant neoplastic growth. So we'll get a component relative to, these are important things when we're talking about, we use component to, when we're saying, does something exist over there? Something about this exists over there that we measure by this thing. And it could be a metastatic deposit in a lymph node. We use that as a component. I'm measuring that thing. And we get through the rest of this. All right. We're going to find it in the browser. Everything is the vast majority of this content is found under proliferative mass observable. That's because proliferative mass subsumes polyp, and polyps are things that we have to measure as part of cancer. So we had to go up to that level. Also tissue specimen observable, because some of these things that we're measuring really are about specimens that we've taken out. Answers are basically determined in the hierarchy where you'd find them based on the property. If you're measuring presence, it's going to be presence, absence, something like that. If it's going to be body site, or what was directly invaded by this tumor, and we're saying, or where did this tumor grow to? And the property is an anatomical location, so you should be looking in the body structure hierarchy to find appropriate answers. So. If you go through this, though, right now we have not done the cleanup. So there is lots of legacy content that, like I said, is beginning of SNOMED time, effective dates 2001, 2002. So when you're looking through those observable entity hierarchies, if it's fully defined, that's when you'll see the if you're familiar, I can open up, but it's the 3 bars in your concept. That means it's fully defined. That's definitely new content, and it's there. If it's not fully defined, you should be looking at the effective date. The effective dates here are anything north of 2018, more likely 2020. Prior to that, they're probably going to get terminated. Sounds really important, doesn't it? Yeah, terminate you. Yeah, sound good. I know, blame Arnold, he did it. Okay. We did terminology binding, so we don't need to do that again. Okay. Any questions up to right now? I just want to, now we get to into the implementation stuff. But it was really important just to get at least a feel for what the assumptions were, what the design considerations were, without going any more in depth, because if I did, then yeah. He's from the Netherlands. He's so handy.
So you claim that all these question and answers, they could be taken out of their context and still be recognized with that particular context. You have not described exactly how that works. Maybe you're coming to it.
Yeah. Bless your heart. Let me show some content. Thank you. That's the best thing about this community. Just, oh, hey, dummy, would you show me an example? Oh, okay. Do we know if the browser's, behaving very well right now with all the people around?
I can
Huh?
I can't get my computer right now. So.
Okay, you know what I can do? I'm just going to go. I'm going to pop over here, just the authoring environment. I'm just going to the authoring environment. It's the same browser that everybody uses, except it's on the authoring side, so it's not getting hit very hard right now. All right, so if you would, histotype, have an organ that you care about? Sure. All right. Histologic type of primary malignant neoplasm of the liver. So how this thing is identify how we've structured this, and it's the only difference between stated and inferred at this point will only affect the parents. Just so you know, it is modeled, we modeled by template. So we followed a pattern. But everything, so we're measuring a property of histologic type. Okay, so now we know what we're measuring. That's a malignant neoplasm that is inherent in the liver structure, and that's a primary. So if you pull that out, that context stays with it, and that's what we were really striving for. And if we're, so same thing with histologic grade or something. Does that help?
It does definitely, but you also have the answer, you also have the finding, and you need to connect that to this.
Yes.
Okay, that's focus.
No, actually, funny you say that. Yeah, I know. By the end of the webinar, we'll be great with that microphone, but then we'll be done.
Okay, so my question is about that. I perfectly understand the explanation that you just gave about the questions.
Yeah.
But if you have a pair with a question and an instance of an answer, and you want to have those connected, which I think was
they have to stay connected.
Exactly.
They have to.
Yeah. Out of this context. So how would you do that?
That's the information model. Yeah. And so honestly, good question. We'll get to that, but I can address it now.
No, let's wait. If I stop your stream, please move on.
There's never a stream of, it's mostly a stream of consciousness than anything. So, but fair enough. But yes, critical to keep these data elements together. All right, so just, so let's just be honest, there are four ways that I've seen this implemented. One I've not seen yet, but I can't wait. We'll talk about that. All right, the world of paper is just never going away. Let's just realize that there are nations that just don't have the infrastructure, and may not for some time have the infrastructure to collect this electronically at the point of care. That's just the fact of life. So there's still paper. So that would be, if you would, you can go to the CAP website, you go to the ICCR website, you can go to the local colleges websites and get paper protocols and pro formas to complete your, the pathologist can then submit it and somebody can abstract it. And so there you go. There's what I call the distributed method, and this is what the CAP is used. This is where there's an electronic structure for the synoptic and a package that can be ingested into an electronic health record system and then use that native application to display the data collection form and record the data elements. This is the approach the CAP took when you guys first started. When was the ECC first? Electronic Cancer Checklist, now called the Electronic Cancer Protocol.
2009 was the first technical release.
All right, so since 2009, the College of American Pathologists has been publishing these bundles, and they're basically XML sheets. There's a reason they did this way, because there wasn't a web-based, FHIR didn't exist yet, SDCs did not exist yet. It's the only way was to get this into a vended system, but then there's a certain risk here, and we'll talk about that, which is you have to trust the vendor to do it right. Okay. Then there's the Dutch approach, which very chintzy. This is tacaño in Spanish, is very cheap. That fits the Dutch, but very efficient. Very efficient. There you go. Central website. They did actually a fabulous job. Within the electronic health record systems in the Netherlands, when the pathologist is ready to call the case, they hit a link. It opens up the PALCA registry website, and there's the synoptic report. It's highly dynamic. So there's conditional logic there, so the pathologist does not have to answer questions that are irrelevant. And then when the report is done, a PDF version. How is it transmitted back, Paul?
Maybe it was too sophisticated, because it's a decentralized system. What is linked to every laboratory? They open a URL from the list system, and it's directly sent back as an XML. And the moment it's authorized, directly sent to the central database of PALCA and to the directly to subsets to different registries. So, but the PALCA protocol module is centralized, maintained.
Yeah.
So,
and so the information
to let's say the clinic.
Yeah, that goes back to the pathologist.
Yes, that will be still flat text, but we're now working with SNOMED CT behind it, and then in the FHIR solution. Yeah,
perfect. So there you go. And then last is FHIR, and we'll talk about that in a minute. All right, so we all know that the paper base still exists. It requires abstraction of data, but here are 4 separate websites to go find templates. The distributed approach, and we kind of talked about that. What are the limitations, the benefits? The benefits are that Intuitive from Glenn Conway back, his company, it helps with this as well. It integrates into the workflow of the pathologist with their electronic health record system or laboratory information system. So their typical workflow is not disrupted. There is some centralized management of the content. Unfortunately, the limitations are that you do require your electronic health record vendor, or your LIS vendor, to be able to ingest the forms, the logic of the forms. And one of the limitations is conditional logic is very hard to create in the CAP form and be universally applicable in a dozen vended systems. So each software platform has its own capability and or weaknesses. So there's certain things the CAP can't force because not all the vendors could accept. But this would be an example of what CAP distributes. It's just a giant XML document of sorts, and they just took a copy of this, Eric. But this is how vendors in a system. This is the system at University of Nebraska. A physician never has to see SNOMED. That's a success. Although pathologists can't add past 10, so they can't. I mean, for goodness sakes, can you add Nottingham score up for me? It's only 9 numbers, man. So at any rate, the physician just interacts with this, and it creates the written report, and it creates, in our institution, we transmit this data in HL7 version 2 back to our biorepository. OBX, for those in the States, OBX3 is a SNOMED question, and OBX5 is the answer, unless it's a numerical answer, and then it's in a different field. But it's very easy. This is Paul Res, if you would, and it's very small, Paul, but that's because nobody else here reads Dutch. So we're saving everybody that, but you can see there's kind of the workflow of the data flow. And that's an example of a little bit larger print, but you still can't read Dutch. So there you go. All right. Other way to do it, and this is what we've started, and this is how we'll try to distribute this content for starter sets for folks. This is a sample fire questionnaire using the National Library of Medicine's form builder. CAP has a better tool in terms of how to interact, but right now, just for lots of reasons, just keeping it here in a very generic form. But this would be the start of a colorectal cancer form, and I'll show you the interactive version here in a minute. Creates a Fire SDC format message, so it creates a JSON message going out that's fully encoded. Can also do it in HL7 version 2, which is a thing of beauty. And if you'd like, I can stay here for a while just so we can, I'll appreciate this work of art. And can you tell me where OBX3 is? Can you? All right. Do tell. Okay. So where to get the terminologies and bindings? So what we're going to do is we are the implementation team, along with Yoon Wang, our graduate student from Korea, and we're never letting her go back to the NRC of Korea. They thought they were sending her to be trained, and now we're just keeping her. Her travel visas outside of the U.S. have been revoked. She doesn't know it yet. Sorry, June. We'll make sure you have a nice place to live in all that stuff. Yeah. All right. So we have radical prostatectomy done. We have invasive breast cancer resections done. We have colorectal done. We'll talk about where we're going to put those, but we will have the rest of ICCR done in the next 6 months or so. Okay. And the format and I'll show you where the format, actually, I'll show it to you right now. Our intention is this is the NLM form builder, if you would. So just so you know, this is what you saw me playing with before. What was the operative procedure, whatnot. And conditional logic can be built in here, which is kind of nice. So there is no perf. I can suppress questions that are irrelevant, or we can expose them. There's importance for that because I used to blame it just on the CAP, but it's actually everybody who makes these forms. I think it's pathology in general, where questions are conflated. More for user friendliness probably than anything else. But for example, the question is what's the focality of the tumor, right? And typical logical person would say, well, how many foci are there, and just give me a number. No, not the pathologists. What's the tumor focality? It's focal or it's multifocal. Oh, if it's multifocal, then how many foci are there? So it goes from some relative distribution, unifocal, multifocal to how many foci. So there's a change in property. I mean, there's a full semantic change underneath the that nesting. So part of the reason why we're going to distribute the content in this form is it accommodates that conditionality. So we can show that here's the proper SNOMED concept to be associated with this conditional question, so that you don't lose track of your semantic. Okay. So that being said, what this ends up looking like is, which is kind of nice, is you do get a full set of SNOMED CT concepts, the URI for both question, answers, and the like. So this is the way, one of the mechanisms we'll provide. There will be a link from the Confluence site, probably to a GitHub site, according to Alejandro. So we'll be able to link out to these value sets. Then we could say that nations can then say, okay, you can take this, but then review with your regional or national authorities on exactly how you want to do this. You may want to add, for example, different histologies to be included in your value set or reduce that number. But this is the intention, is distributing this as an SDC questionnaire package. Maybe there's a flat file way to do that as well. We'll look at that. All right, so the data storage and analytics, how are we doing on time? Oh gosh, okay. So, and there's a question out there. Should I check? So that would be a Dutch pathologist in Sweden, and he's just crazy. And yeah, we'll see what he responds. So we'll come back to that. So. Remember how we said there's this information model. So there's a case, right? And then there's a part, or many parts, and then a gross description and microscopic description, ancillary studies, and ultimately your synoptic report. It's critical that you maintain some semblance of that structure, the grouping, right? It could be, but more often than not, at least in the US, it would be a case number or an accession number, if you would. But the data can often be pulled apart. But we're saying you have to be able to keep those question answer pairs together. So this is how we do it at University of Nebraska, and this is our biorepositories. And I'm happy to share this, in more detail. Basically, what we do at the University of Nebraska, and we because we do want to be a little cutting edge, we use both a graph database and a relational database. And actually, we do it in the same database engine. SQL Server actually has graph functionality. It's not as fancy as Neo4j, but it's for what we use it for, it's more than sufficient. So 100% of all SNOMED is maintained in a graph within a Microsoft SQL Server graph, and all the row level data about all the cases is maintained in a relational database format. So what you'll see here is that we have a case, a patient has a case, patient could have more than one case, right? They have a part, and then there's a synoptic report. Usually in the US, almost exclusively, the synoptic report is associated with one part, even though there may be data on other parts that contribute to that case. But the synoptic is almost always bound to one of the parts. And then there's a series of synoptic observations, and those are all SNOMED CT encoded. Okay, but we do have to keep them pairwise. We do that. And so in this case, the synoptic question and answer are kept in a table. So the table for the synoptic observation is there. So each synoptic report will have many, it's a one-to-many relationship by table. Does that help? Okay. So, all right. Any questions heretofore? Okay, then the thing is about this is you still have to, this is where we did a workshop yesterday with Jim Campbell, the utility of description logic. So basically, why use SNOMED? Well, it's because of its knowledge graph capabilities and capacity. In one way to explore that is using ECL. Graph database is the other way to do it. So at runtime, we use a graph database, which is really nice. But for purposes of discussion or visualization, we do this. So I'm looking here in ECL query, give me all the subtypes of primary malignant neoplasm refined by the inherent location. So I want to look at all digestive tract systems. And of course, as when you say the entire digestive system, little Nebraska humor, it takes you from the asshole to the squeak. So basically from your mouth to the, that's just a farmer saying that we process everything except the asshole and the squeak. Right? I don't think you can process air, but you might. Anyway, so we get a laundry list of concepts. I can refine that eventually, but this returns 19 concepts. I can refine it and say, hey, give me the gastrointestinal structure. We get a smaller number of concepts, but I still get everything in the GI system. I can start looking across multiple axes. So I can start to say, hey, I not only do I want to look at the GI system, but I also want to look, malignant versus non-malignant tumors. So I can start to do all sorts of nice queries. Now, this is just querying terminology, right? So, yeah, this is querying SNOMED and getting SNOMED responses. But in the production database, what you're doing is you're basically getting your inclusion criteria. And when you get your inclusion criteria, then you can they're associated with your encoded data. Now you're bringing your patient level information forward. So that's really important and really the important aspect here. So what's next for this project? Just so folks know, we need to complete all the terminology binding for all the ICCR content. We really do need to now start training. So this is a first start. So thank you for being patient with 2 hours of hopefully helpful information. But we do need to train here. It's great to have a product, but if nobody uses it, big whoop. And really we have to start training our user community. This is a big deal for the body pathology. Now we have to start laying it down in our systems, understanding what we're laying down in our systems, understand how to utilize that data, how to communicate that data, and use it for patient care first, right? How are we using it for patient care? How are we using it for quality improvement? How are we using it for research at our care institutions and public health? How are we taking care of the population? So the other thing that people ought to know as part of this project, what we started to find is, and drove me nuts. All right, I want to see all the histology. I want to see all the adenomas, malignant adenocarcinomas of any subtype in the colon. You can't do that yet because the histology side or the morphologic abnormality side of SNOMED has not been attended to in a while. Nikki and I have been diving into that. So what we have started in conjunction with Nikki, the people at IARC, so the Blue Book, and others, pathologists, is doing a complete overhaul of the morphologic abnormality hierarchy in SNOMED to bring it into conformance with the 5th edition of the Blue Book, getting rid of things that don't exist anymore or have been conflated. Refreshing the terming as it's referenced today or in the recent past, and getting that so that we can get a repeatable, reliable level of performance in our morphology hierarchy, because this is really important for the other half of the query. But we found that through the course of this project. It's like, oh my gosh. So the biggest issue, frankly, were neuroendocrine tumors. And for those who are in that space, they were conflated. Neuroendocrine tumors and neuroendocrine carcinomas were conflated. And we know they're not supposed to be conflated. So we've just finished our revision there. It's just in the let everybody know before they freak out that, neuroendocrine tumor grade 1, 2, and 3 have been deprecated, and they're now called well-differentiated neuroendocrine tumor grade 1, 2, and 3. Not to be confused with neuroendocrine carcinomas, which are different. And oh, by the way, there's no such thing as a benign or borderline neuroendocrine, well-differentiated neuroendocrine tumor. So according to the blue book, so you won't find those anymore. They will all be malignant. Lots of people to thank. Lots of people to thank. The first guy on the list, Paul, he's only there because I felt bad for him. No, Paul was awesome. Ryan Roos, you guys can read the list, but they're just fantastic number of folks who have helped. All right, any questions on that? Paul? There's a question from Sweden? From Stefan?
Can you read it?
Yeah, no, it's gone.
It was a question about the online.
Oh, yeah. Oh, no, he looked, he's happy. It's Friday. He's probably having his beer right now. It's about that time of day.
Yeah, I'm coming back to my question from, because I'm not really satisfied yet with that connection between the questions and the answers. It might be that some of the value sets that fits, they have overlap. So in one area that has concepts in it, that could be an answer to it. Somewhere.
Yeah.
So therefore, I would like point make sure that right and still that also take that on a particular question. So that I think it's possible because it's a known relationship between you can write an Excel that can do that, I'm quite sure. So you get
No, I do. So no, and there's a great point. And so we're actually developing something like that now. So and Stefan Dubois, who's on the phone and I'm or on the call, is one of the investigators doing this. So what we're doing is and I'm hoping I can leverage the CAP's infrastructure to help with this. Sorry, Erica, you're on the spot. But what we're doing without the CAP right now is, all right, here's a representation, let's say, of let's just stay within one organization, the CAP. So here is the protocol for breast tumor, okay? And here's the protocol for colorectal tumor, right? And that adenocarcinomas will exist in both. There's an answer, right? So what we've done is we've leveraged the inventory system of the CAP, and we're imputing that on other organizations as well, at least in our management of it, that we can say, okay, I want to see all of the question answer responses for histologic type between two data sets, whether it's of this same organ but by different publishing bodies, or different organs by the same publishing body. So in that case, what I will get is I will get an intersection of content. So I'll get, there'll be a Venn diagram in essence. Here's a series of histologies that could be shared, exist in both. And here are histologies that are either in one or the other, but not both. So we're doing that more on a knowledge management level. And so the instance data for any particular case, you saw that. Yes. Yeah. But in terms of management, like this value sets, that's how we're trying to do this. So, adenocarcinoma has one SNOMED concept. So, but it could be used in multiple different data sets because of that type of neoplasm exists in lots of places. So that's how we're trying to do that. So we have the inventory bound with SNOMED, but then when we do our queries, I couldn't do this in an ECL, I don't think, but I could do it with a graph query because I have to look at multiple axes, but in disjointed, question and answer, they're different. So, but I can create the overlap and the difference between the two.
There is a mechanism called findings with observations. So there is an association between those. And you can use that to declare that this was the answer for this question.
You could, and you can do that in some of the areas, but not all. So some of the observations that are made by the pathologist, if you were to try to pre-coordinate those into a clinical finding, you would have to change the machine readable concept model for the allowable domain and range of an answer. So
that could, I mean, it's possible to have that connection, and I think it is essential. And I also think it is essential to have it outside of the database where you actually have these, because it's a logical connection between things. And you would make that portable, I think, between systems if you had that declaration. But it's a detailed discussion, and I think what I've seen is a fantastic job. So it is a small detail way down in the structure of all this. But I think that as you stated several times, pathologists, they look for details. And therefore, you will end up having questions about these things if you do not quite solve them beforehand. So,
and I appreciate it, because we get to we're at that point where we're turning the page now to complete one part of a project, which was important. And now this is the time to solicit that input, because we're really at that point where, okay, here's the content. Do we need to change any? That's always open for discussion. But how do we implement this, and how do you make it portable and implementable? I think it's implementable now, Lisa, but could it be better? I hope, because right. I mean, we started here, but that's the challenge. How do we make it better? How do we continue to extend this, refine it, improve it, so that it becomes more useful, more interoperable is a silly word in this context, but to your point, just
yeah, but I get it, and you're welcome, by the way.
Thank you. Yeah, absolutely.
Another important part in that, Scott, is going to be the implementation, how the vendors use this next, which I know, Intuitive does a really great job of doing this. I mean, Epic's been working on SNOMED integration. Cerner obviously has too, just to name a few of them. I think that's going to be the next steps. This is how do we get that education out there to do this, as well as how do we get these graph queries, as we will call them.
Yeah. So I feel like it's time. That's the phase we're starting to
exactly
get into. You're talking U.S. vendors.
Yes.
When we talk about clinicists, for example, now we're talking clinicists across multiple platforms, not just the ones we're used to in the States, but the ones in the UK are, it's a challenge, right? I mean, Glenn's got to deal with that and how to take care of that, how to do it with digital whole slide imaging. Sometimes several organizations are wishing to bring synoptic reporting into that platform and then just have it an output to the LIS or the EHR.
The other question I was going to ask you was going to be, do you see connections between this and surgical synoptics going forward as well? And that's
well, sure. I mean, to the extent that any specialty wants to apply synoptic level reporting, absolutely. I mean, radiologists as well, right? I mean, if you can get a radiologist to do that.
Sure.
Oh, Matt, you're done.
No, I thought I'll get one. I think it's really good to see, Scott. Like, this has been cooking for years and years.
Yeah.
So, but one I did like said that you're looking at the morphology work now. So, I think that's one thing we've noticed, that there's these primitive hierarchies don't get a lot of love, but they build all the other bits of content.
Yeah.
But the question I had about the value sets, and then are they published individually? I'm not really familiar with the questionnaire resource, but I don't know. Are they the answers for each of those observables, are they built within the questionnaire, or?
That's what we'll do. Yeah. So for example, RCPA, and the value sets are there in language, natural language. So we're replicating all of that as an SDC. So you'll have all the value sets encoded associated with the published document.
Yep. Yeah, that's what I'm thinking. How do we get that? So we host all those value sets separately and then do the value set binding between it. So no, looking forward to trying to get.
Yeah, so our goal is to actually have them done.
Yep.
Available on Confluence and then, distributed. Now, we'll also work with the ICCR. They have to, they're going through some changes left, but we're trying to make a formal relationship there with SNOMED. But I've been working with them. Paul's been working with them. So, and we're trying to build this infrastructure. Here you go, ICCR. Now you've got to get it to your user community.
Yeah. No, excellent. Thanks.
It's Friday and it's lunchtime. Thanks, everybody.